Welcome to HIM 216. This is the second lecture for Chapter 2. In your textbook, we're on page 16. Additional documents that you may use for coding include nurses' notes. There is some documentation that we can pull out of nurses' notes and use. We can use staging for decubitus ulcers. Also BMI for patients, maybe documented by a dietitian or by nursing. We also use the anesthesia form. Anesthesiologists are physicians. They do evaluate patients prior to surgery. And during that procedure, they monitor the patients for fluids they receive, any blood loss they have. The anesthesia form also includes a pre- and post-anesthesia assessment, the type of anesthesia used, the amount, the route of the administration, and of course the duration of the procedure. Another key document that we'll find in the medical record and that we'll code from is an operative report. An operative report has to include a pre- and post-op diagnosis, the date of the surgery. It also must include the name of the surgeon, the actual findings of the procedure, the procedure performed, and then the condition of the patient at discharge, and it has to be dictated within 24 hours. In your book, on page 23, you'll find an example of a written progress note. Page 24 also has a progress note. If you look at page 26, 27, 28, and 29, these actually M30, these are actually anesthesia forms. And then the operative report is included on page 31, and you can see that it does include the required documentation. And when you look at these anesthesia forms, they include the exam by the physician, and that is information that you can use when you're coding. And then if there were any intraoperative or postoperative issues related to anesthesia, you'll find that documentation as well. Another document that you'll be using in coding will be a consultation report. And actually the attending physician writes an order for a consultation. So an internist may write an order for a consultation with a pulmonologist. The pulmonologist actually comes and assesses the patient, performs a physical exam, and he dictates a report called a consultation report that is very specific to his specialty and the exam that he performs. Sometimes the consultation report is written within the progress note, but they will label it as a consultation, but usually they dictate those. It's usually a separate dictated report. Now, also included within the medical record are ancillary reports. For instance, if you look on page 25, on the bottom of that, figure 2.8, this is an example of a lab result. We don't code from lab results if we don't have clinical documentation, and we'll talk about that more in the course. And then if you'll look on page 32, this is an example of a radiology report. Radiology reports are always dictated and transcribed. Now on page 33 is an example of a discharge summary. And the discharge summary should include the history of the present illness. It should include the past medical history, the findings, any lab data, the results of treatments performed. It should have a final diagnosis and discharge information. And if you look at the discharge summary on page 33, you can see that it has hospital course, and then it has the discharge diagnosis, the meds, the diet, the activity, and the follow-up. And those are key elements of a discharge summary that should be included in your discharge summary. Now, for this lecture, I want you to look at exercise 2.1 in your textbook. Exercise 2.1 starts on page 33 and extends to page 34. And for your question for this lecture, I want you to answer question number 1 and question number 7, that's on page 34. And then question number 9. So those 3 questions. And so you'll answer those questions and submit this assignment. Now let's go on to the, and by the way, you'll have another question in this lecture. So the lecture's not over. So as we look on page 34 in your textbook, we are looking at Uniform Hospital Data Set, UHDDS, Reporting Standards for Diagnoses and Procedures. So while we have coding guidelines, official coding guidelines, UHDDS actually defines a principal diagnosis and a principal procedure. And so we are going to look at these definitions. One of the most important things that you do as a coder is determine the principal diagnosis and the principal procedure. Just because the physician documents or lists first a diagnosis on a discharge summary doesn't necessarily mean that it meets the requirement, the definition of a principal diagnosis, or that the physician has followed the official coding guidelines. So I want you to, on page 34, towards the bottom where it says principal diagnosis, this is something that you need to put on a note card. I always ask my students, how are you going to study this so that you can learn it? And we're not talking about just memorizing it. The things that you're learning beginning in Chapter 2, you will have to apply throughout this entire textbook. And the principal diagnosis is one of those key things. So periodically, I'll recommend that this is a note card. And I think you should buy index cards and have a term on one side and then the definition on the other side, and this is something I would put on one of those cards. So the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So the condition determined after study that occasioned the admission. Your book tells you that this is one, if not the most important concept that a coder has to understand and apply. The principal diagnosis and the principal procedure determine the assignment of the Medicare Severity Diagnosis-Related Group, which we call MSDRG, and that affects reimbursement. Physicians are not often, they have no idea of what the definition is, how it's applied, or what the impact of it is. So the coder has to take care, they have to understand the official coding guidelines to correctly assign the principal diagnosis. So let's look at this example on the bottom of page 34. The patient comes into the ER with a cough and a fever. They do a chest x-ray and they determine that the patient has pneumonia and the patient's admitted. The principal diagnosis here is pneumonia. It is not cough, it is not fever. Those are symptoms of pneumonia. They are actually integral to pneumonia and they are not coded at all. Let's look at the top of page 35. A patient comes to ER with acute abdominal pain. After the patient's evaluated, they go to OR and they have an appendectomy, and the pathology report shows that the patient had acute appendicitis, which is confirmed by the physician in the discharge summary. The principal diagnosis is acute appendicitis. It's not abdominal pain, and we don't even code the abdominal pain. It's a sign on a symptom, and it is integral to acute appendicitis. Integral meaning that when patients have acute appendicitis, they have abdominal pain, so it's a component of that process. Then your book tells you that sometimes it's not really easy to identify the principal diagnosis. There could be a secondary diagnosis that utilizes more resources, but that doesn't mean it's the principal diagnosis. So let's look at this example. The patient came in for coronary artery bypass surgery with a diagnosis of coronary artery disease. So in this instance, the disease is coronary artery disease. The coronary artery bypass surgery we would call a CABG, C-A-B-G. It's coronary artery bypass graft, and that would be the procedure. That is not the diagnosis. So they perform surgery, and on the 4th postoperative day, so the 4th day after surgery, this patient gets pneumonia. The pneumonia is severe. The patient goes into respiratory failure. They have to be intubated, which means that they're put on a respirator, an ET tube is inserted and they're put on a respirator, and they're treated in ICU. The patient stays in ICU for 10 days. They cannot wean that patient from the ventilator, meaning that every time they try to take that patient off the ventilator and get them to breathe on their own, they can't do it. They can't. If they take them off the ventilator, they won't breathe. So they perform a tracheostomy on this patient, meaning they go into the trachea and they put in a device so that they can attach this patient to a ventilator that will breathe for them, and then they send them to a rehab facility. So when you look at all of this, probably the worst thing that happened is that the patient got pneumonia, had to have a permanent trach. But that's not the principal diagnosis. The condition determined to have occasioned the admission is the coronary artery disease. That is why they came in. The principal procedure is the coronary artery bypass graft. Do we code the pneumonia? Absolutely. That is a secondary diagnosis code. Do we have a procedure code? Actually, when we code the CABG, that's a PCS, procedure code. We actually will code the fact that this patient was on a ventilator for greater than 96 hours. That's another PCS procedure code that we'll use. So then we have guidelines for the selection of a principal procedure. And in your book, we're on page 35. So when we're talking about the sequencing, and that's when we're talking about a principal diagnosis, we are talking about the diagnosis code that we list first. That drives the DRG. When we talk about a principal procedure, we're talking about the procedure that we list first. And when you think about listing the codes, think about literally you list one code, below that you list another code, below that you list another code. So it looks like you have a list of codes. There is one and only one principal diagnosis code. I want you to write that on a card, because some of you are going to think that there can be more than one principal diagnosis. There cannot. There is one and only one principal diagnosis code or principal procedure, but there can be many secondary diagnosis codes and secondary procedures. And usually, just from a coding standpoint, it doesn't matter how you sequence secondary diagnoses or secondary procedures, but correctly sequencing the principal diagnosis and the principal procedure is critical. So when we look at the selection of the principal procedure, it says follow these instructions when you're assigning that code. The procedure performed for definitive treatment of both the principal diagnosis and secondary diagnoses is sequenced as the procedure that is performed for the definitive for the principal diagnosis, the definitive treatment for the principal diagnosis is the principal procedure. So in our example up here, our diagnosis was coronary artery disease, and our definitive procedure was the bypass, the coronary artery bypass graft. A secondary diagnosis was pneumonia, and a procedure performed for that was the tracheostomy. So we are sequencing, in that example, we're sequencing the coronary bypass graft first because it's a definitive procedure that's related to the principal diagnosis. Okay, if we perform a procedure for definitive treatment and diagnostic treatment for the principal diagnosis and a secondary diagnosis, then we sequence the procedure for the definitive treatment that's most related to the principal diagnosis first. So for instance, think about a patient who has a breast mass. And first they have a breast biopsy, and then they have a mastectomy. The mastectomy is the definitive procedure, and it is sequenced before the biopsy of the mass. The biopsy of the mass is a diagnostic procedure to determine whether or not that patient has cancer. The definitive treatment is the mastectomy. So in that example, we'll say that our patient has breast cancer, so they had a diagnosis. They came in because they had a breast mass. A biopsy was performed. It was determined the patient had cancer, and they did a mastectomy. All of that done during the same admission. Our principal diagnosis is the breast cancer, and our principal procedure is the mastectomy. The mastectomy is the definitive procedure performed for the diagnosis. The biopsy was a diagnostic procedure that was performed. The third guidance is if there's a diagnostic procedure performed for the principal diagnosis and a procedure is performed for definitive treatment of a secondary diagnosis, then we're going to sequence the diagnostic procedure as the principal procedure, since the procedure most related to the principal diagnosis takes precedence. So in trying to think of an example of that for you, let's say that a patient has pneumonia and they also have gangrene of the little toe. So they come into the hospital for treatment of the pneumonia, and they have a diagnostic bronchoscopy. And they also have an amputation of that little toe due to the gangrene. Well, the amputation is a definitive procedure. The bronchoscopy is a diagnostic procedure. However, we would sequence that bronchoscopy as our principal procedure because it's most related to our principal diagnosis of pneumonia, and it takes precedence. So in then number 4, it tells us that no procedures were performed that are related to the principal diagnosis, but a procedure was performed for definitive treatment, and a diagnostic procedure was performed for a secondary diagnosis. So we would sequence the procedure for the definitive treatment of a secondary diagnosis as a principal procedure. So an example of this is, let's say that a patient comes into the hospital with pneumonia and they fall and they break their hip and they have to have a hip replacement, or a reduction of a fracture of the hip. That is a definitive procedure, and we would sequence it as the principal procedure, even though it's not there's no procedure for the pneumonia. They fell out of bed. So we don't have a procedure for our pneumonia. So the repair or the reduction, the open reduction and internal fixation of the femur becomes the principal procedure. So your question, I'm going to end this lecture here. We'll pick up on the bottom of page 35 in the next lecture. And your question, your final question for this lecture is, when you combine the principal diagnosis and the principal procedure, they drive reimbursement. Which reimbursement system do they impact? So when you have a principal diagnosis and a principal procedure, and they determine reimbursement, what is the system that they discuss in your book that these codes impact? And that will end this lecture.